So Kristin Newby is from Duke University, the co-chair. She looks very young, but she's been involved in this field for more years than she'd probably like me to tell.
So I got the challenge of talking about troponin elevations in the absence of overt ischemic heart disease, which is a great follow-on to Joe's talk and the discussion we were just having. I'm going to be pretty brief. I'm probably going to be more provocative than I'm going to answer questions. But let's think about why we measure troponin. And obviously we measure troponin because we're looking for myocardial infarction. We want to make a diagnosis. And Joe's nicely outlined how we're thinking about that. There's some tweaks that are happening to the definition, but I think we have a pretty good working document. We also measure troponins, and I think this is important, and it's not part of the definition of MI, but it's an important perspective on troponin testing, and that's to establish future risk and prognosis. We also, hopefully, can use this testing to help us figure out how we want to treat a patient. So how do we guide therapy based on a positive troponin? And I think this ties in nicely also to the discussion that was just going on. And it may be possible that we can use troponin to identify treatment toxicity. And I think of this in the context of like anthracycline toxicity, which is an elevation of troponin in the absence of overt ischemic heart disease. Joe just went through the universal definition. The thing that I just want to reemphasize before I go into what I'm going to talk about is that this requires a clinical syndrome that's consistent with myocardial ischemia or infarction. So as long as we have that framework, I think it helps to think about elevations in other settings. So before we really go to that, let me just talk a little bit about troponin elevations in the setting of what we think is ischemic heart disease and ischemic clinical syndrome. And again, ties right into the discussion that we were having. We have a fairly good relationship between troponin elevation and prognosis, which is our second key point. That's persisted even with newer generation assays that have limits of detection that are now below the 99th percentile. So that relationship is holding up, and that's, I think, an important relationship. We know that there are some treatments that we can apply that seem to have a greater benefit when we use them in patients who have elevated troponin. So we have a potential third element there that we can guide therapy. Now, the caveats there are most of these studies were done with older generation assays. It's uncertain what's going to happen to magnitudes of treatment benefits as we move to lower level elevations. It may be, and this makes sense, that if we're looking at antithrombotics, antiplatelets, that the treatment effect you might expect would be greater for type 1, and there have been some sub-analyses, one of the Triton-TIMI 38 study that suggested that that is indeed the case, that we need to be thinking about how we use troponin elevation in the context of why we think the troponin is elevated, and that's how we make our treatment decisions. So another caveat here that I think is challenging, and Joe touched on this, is that even when we select populations that have ischemic symptoms, they're classic ischemic symptoms, in this case selecting them into clinical trials of therapies for acute ischemic heart disease, somewhere around 10% of those patients are not going to have obstructive coronary disease, and a smaller proportion will have normal coronaries. Now that number falls if we use high-risk criteria, ST segment depressions or transient elevations on the EKG or troponin positivity to select the patients into the trials. It may be as low as 7.5%, but it's not negligible. And if we look at the patients with no significant CAD, up to 40% or more of those, depending on how we selected them, will have an elevated troponin, plus or minus electrocardiographic changes. The important thing here is that we don't totally write off those patients as not having, in this case, an acute myocardial infarction, and certainly that we think about them for secondary prevention, especially if it's insignificant disease and not totally normal coronaries, because they have, as you can see here, not negligible risks at 30 days and 1 year for mortality or recurrent ischemic events. So that kind of begs the question, when should troponin not be tested? And I don't think there's any way to really answer that question. I think we just have to keep in mind that the troponin assays are specific for myocardial necrosis, but they don't tell us what the etiology of that necrosis is. And this gets into the discussion of the type 2 or even beyond that, absolutely no ischemic etiology. So I think if we think about troponin testing and we think about it smartly, and we're not testing as a screening tool in everyone, that we test when we think there's some likelihood of the ischemic event, we limit our false positives, so to speak, and we think about troponin testing in the context of whether we have a downstream management strategy that we can apply based on the results of that testing. So we have somewhat of an exit strategy. Now, that said, there are the cases where there's diagnostic confusion. The clinical scenario absolutely sounds like it could be a myocardial infarction. And that can be acute heart failure. You're going to hear a little bit later about troponins in heart failure, pulmonary embolus. I'll show you, just take you briefly through a case of pulmonary embolus, hypertensive urgency, even COPD flares where patients come in with chest tightness and shortness of breath. These patients have underlying coronary disease, and I think you have to have a high clinical index of suspicion, but we often get to the cath lab and find that there's no new lesions or there's no lesions at all. So are these type 2? Are these just incidental findings? I think that's to be sorted out. So here's a classic case. 6-year-old woman, she has diabetes, hypertension, she's a smoker, she comes to the emergency department. She's had substernal chest pressure and shortness of breath for about 2 hours. She's a little bit tachycardic, her blood pressure is elevated, she's anxious, her EKG is not particularly helpful, nonspecific ST changes and sinus tachycardia, normal chest x-ray, and her troponin is elevated. We see this every day, and we're not going to get around this. We would be remiss if we didn't test in this setting. So this patient's having persistent symptoms. She goes to the cath lab, and her coronaries are normal. So now we go down a diagnostic workup for why is that troponin elevated. And I think this is perfectly reasonable. It's what we should be doing. So she gets worked up with a VQ scan. That's high probability. The echocardiogram shows a mild decrease in RV function but no RV dilatation. She's, as I told you, hemodynamically stable. We're not going to act on that troponin now. There's no evidence that treating with fibrinolytic therapy based on a positive troponin or other therapies are going to improve her outcome. We do know that having a positive troponin in the setting of PE, like any or many positive troponins, is associated with worse outcomes. But in the absence of hemodynamic compromise, profound hypoxia, she's going to get heparin standard therapy for the PE. So we just need to think, once we have that troponin, we pursue the diagnosis for why it may be elevated in the absence of overt heart disease, and we treat based on the guidelines that we have for the disease that we find. So it doesn't, unfortunately, it's not always PE, and I adapted this from a paper that Alan had written several years ago now, looking at a number of causes, and I've taken the liberty of trying to put them in little buckets just because I think in buckets. But you can see that there are a number of clinical scenarios in which if we measure a troponin, we are likely in a certain proportion of that population, particularly as the assays become more sensitive, to pick up elevated troponin. So I think this is where the concept of, in the absence of ischemic symptoms or changes in the patient's condition that make us think that there may be an ischemic event, we need to be careful about pulling the trigger on troponin testing. Some of these may be truly type 2, vasospasm, pulmonary embolism, probably not, though. We'd have to think about that in the absence of hypotension. It becomes confusing, and I understand in practice and in the discussion that we're having here today that it's hard to really sort out what to do. But I think if we're prudent about testing and thinking about how we can actually treat patients who have a troponin elevation, we'll be smarter about how to work our way through the type 2s and the non-type 2s that have elevated troponins. So what's the prevalence of troponin elevation in the absence of overt ischemic heart disease? And now we're talking about things like heart failure, et cetera. Well, it's a moving target, in part because there's not systematic assessment of patients with these clinical entities that I just showed you to get a handle on what the absolute prevalence in that specific disease area is. We also know that the initial studies that were done used older, less sensitive assays, so any detectable troponin was abnormal. And we could expect that as the troponin assays are more sensitive, the prevalence would go up if we systematically measured it in all patients with that disease entity. And I think there, where the 99th percentile falls out is going to be helpful, at least in distinguishing abnormal from the normal population, if you will. So what about diagnostic workup? Well, in general, if we're in sepsis or we're in hypothyroidism or any of a number of other reasons that troponin may be elevated, our workup and how we work it up depends on what disease area we're in. Coronary disease in many of these other clinical settings is of low suspicion, although many patients around the world have underlying subclinical coronary disease, so we always have to have that in the back of our minds. But in general, the workup is dictated by the patient's clinical course with the disease that they have. As I mentioned earlier, prognosis in general is worse with troponin elevation than no troponin elevation, regardless of whether it's sepsis or renal disease or hypertensive urgency or heart failure. One exception that I think is kind of interesting is strenuous exercise, which there's been a lot of discussion about, and I'll show you a little bit of data on that. Specific treatment recommendations outside of potentially stopping anthracycline treatment, there just are very few recommendations for how we act upon that positive troponin to alter the patient's clinical course. Renal disease, just a couple of words because it also creates, I think, a lot of confusion. I think the thing I want to emphasize here is that if you have a patient with end-stage renal disease and they have symptoms that are consistent with an acute coronary syndrome, it's still an acute coronary syndrome until proved otherwise. If the troponin is elevated, they fit within the definition of the universal definition of MI, and it represents an MI. It's certainly associated with worse prognosis, and it warrants the same type of invasive workup and treatment as a non-renal disease patient who presents with classic symptoms and an elevated troponin. Now, in the absence of acute ischemic symptoms or EKG changes, it may be reasonable in end-stage renal disease patients to have a baseline troponin that one can compare to. There's somewhere between probably 30% to much higher. Alan, you could probably quote numbers on that, up to maybe even 70% or so of patients with end-stage renal disease who will have a positive troponin if you check it. It may relate to fluid shifts, volume shifts at dialysis, blood pressure control, many of the other things that we looked at on the earlier slide. It's definitely associated with worse outcomes. So troponin T actually is labeled for prognosis. I think probably having an elevated troponin I also carries prognostic significance, even though there's not specific labeling around that. So if you see it, it may be prognostically helpful to you. It may represent subclinical underlying coronary disease or simply other factors related to the dialysis state. Troponins troponin elevations in the setting of exercise I think are fascinating. This came from a recent paper from last year in 2010 in JACC, which was basically a systematic review of the literature on troponin elevations in exercise. And largely we've thought of this as elevations that occur in the setting of distance runners, marathon runners, or half marathons. But it's actually interesting that if you look at this top study here, these are people who are doing moderate walking exercise but who were not in great shape at the time that they started doing it. And even in that population, if you systematically measure them, 18% of them have elevated troponins. So I think the message here is not that we don't want to encourage exercise. We do, but realize that, particularly in the ultra distance runners, up to half to, depending on if you're using a high sensitivity assay, almost 100% of them will have some elevation in their troponin that's transient. It doesn't seem to be correlated with MRI findings. It doesn't seem to be correlated with downstream reductions in ejection fraction, but it does it does kind of muddy the waters in terms of these isolated troponin elevations and what they mean. And I think at this point, further work is needed. In the meantime, if they're not complaining of ischemic symptoms, don't send them to the cath lab right away. Treat their bruised knees and blisters on their feet, but don't go overboard. So to sum up here, I'm just going to say that troponin elevation in the absence of overt ischemic heart disease occurs in many cardiac and non-cardiac illnesses. Most, or maybe all, troponin elevation is prognostically significant, the caveat being the people who are exercising, and I think we just don't know there. In most situations, outside of vasospasm, for example, we really don't have a specific treatment to base on the troponin status. And so I like to think of testing not as a routine screen, but as clinically driven, and I think that will help us sort through some of the problems with the type 2 or absence of overt ischemic heart disease troponin positive patients. Thank you.